Dr. PRAVEEN VENKATAGIRI is a consultant neonatologist at Chinmaya Mission Hospital and O1 Group of Hospital, is a founder and co-founder. So, Dr. PRAVEEN, over to you.
Yeah, thank you. Start. Okay. Fine. There you go. Good evening, everybody. So, what is this? Okay. Thank you, everybody, for joining. So today, I'll be talking about congenital hypothyroidism and very briefly on thyrotoxicosis as well. The aim of today's presentation is to discuss why we should be worried about congenital hypothyroidism, how do we screen it, and how do we interpret the result. That will be the main thing, and also what investigations options are available, and how do we treat that, and also briefly on how to implement the screening program. So today's talk mainly will be based on the recommendations from Indian Society for Pediatric and Adolescent Endocrinology, which was published in 2017, and which was again based on the European Society for Pediatric Endocrinology consensus guidelines. Overall, about 50 slides, so it should take around 25-30 minutes to complete that. So why should we worry about it? So we'll be briefly looking at the prevalence of the problem, what is the impact of the disease, and the outcome of early treatment. How significant is the problem? If you look at that, various publications since 1984 to the latest 2014, our own Kishore Kumar's publication from Cloud9 group showed that clearly congenital hypothyroidism is a significant problem in terms of 1 in 1,000 babies are affected with it, which is very high compared to the Western population, where it's probably around 1 in 3,000 or even higher. That's with the large population of Indian size, several babies will be affected because of that. And that's why this data is extremely important. So also, most common cause of preventable intellectual disability is congenital hypothyroidism. Important to note that it's a preventable and easily you can diagnose as well. So you look at the intellectual disability amongst the unscreened children. The cohort publications from Sweden and England showed that, I'm sorry, for some reason the animation is not working, but I think we can live with it. So the mean IQs are much lower in these children who have not been screened and later have been found to have lower IQs. And also, what is the impact of initiation of the treatment at different ages? If you start the treatment before 3 months, the IQ is around, mean IQ is around 89. And if you delay up to 6 months, it goes down to 71. And if you delay beyond 6 months, it goes further down to 54, which is very significantly low as such. These findings are confirmed in nearly 11 studies where it was shown that if you start the treatment before 30 days, anywhere between 12 to 30 days, it has led to 15.7 points higher IQ when compared to delayed treatment. They're present with various symptoms and signs, many times even without symptoms as well. But the common presentation could be prolonged jaundice and feeding difficulties and lethargy, and the findings of umbilical hernia and macroglacia are seen as shown in this image. So prolonged jaundice, puffy face, and wide posterior fontanella is a classic thing that we tend to see. What are the causes of hypothyroidism? Now, there are permanent causes leading to permanent hypothyroidism, and there are causes which are transient hypothyroidism. In the permanent, the most common is the primary, that is the problem within the gland itself. So what is the problem within the gland? So the gland Position itself is a problem, the structure itself. So it is not present in the usual place, it is in the ectopic different site, hence the architecture itself is different, or it is not well formed itself, or the gland is not responding within the gland to the stimulant, which is the TSH. And the other one is internally, the architecture wise, the hormone is not producing the thyroid hormone in a adequate or in a proper manner as such, because of defects in thyroid peroxidase or sodium iodide importer defects. What are the central causes? The central is the stimulants from the brain. So from the hypothalamus and pituitary. So the TSH deficiency could be there, or TRH deficiency, or any problem with the pituitary stalk itself. And also any receptor gene mutation also could lead to central cause of hypothyroidism. What is the peripheral cause? That is, you have a hormone which is secreted, but it is not going and causing any effect because of the resistance to thyroid hormone. And other cause could be that the abnormalities of transport itself. It may not be even able to reach the target tissues as such. The syndromic or functionally, the tissues itself are not able to deal with the hormone or process the hormone itself. There are various, and the list is not exhaustive. There are many more that you can find in the textbooks, but they're all more, they're not common as such. The transient cause, which could be related to the maternal intake of anti-thyroid drugs, transplacental passage of maternal TSH receptor blocking antibodies, or iodine deficiency either in mother or in the neonate. Sometimes hepatic hemangiomas also could lead to transient hypothyroidism. So when you look at what is a common etiology of congenital hypothyroidism, mostly it is a primary, in the permanent causes, it's a primary congenital hypothyroidism, and mostly the ectopic thyroid is the most common cause of permanent congenital hypothyroidism. So how do we screen that? Again, I'm showing the same the table, which shows the significance of the number of the babies affected in Indian context. And based on this itself, we can say that the number of the babies that we can protect will be very high. Hence, newborn screening must be done for every newborn born in our country. So that's the recommendation number one. What sample do we need to send? Now, again, there are in the same study as well, two kinds of samples were sent. Generally, you look at whether it's a cord blood or the postnatal sample. So how do you decide that? For that, like, we need to understand the TSH surge, which occurs 30 minutes after the birth approximately, and that persists for about 48 to 72 hours. So during this period, if we do the test, it could be falsely high. So the decisions need to be based on the place that we are working in. If you have large number of babies born in, and also you're discharging very early before 48 hours of age, and also if you're not sure of the follow-up that they will come, probably you could consider doing the cord blood sample, where it's freely available, but we do need to understand that the resources to do that, somebody has to be dedicated to take the blood sample and send it. And how do we ensure that no baby is missed? If you can have the system of making sure that every baby's blood is sent immediately after the birth from the placental blood, then you will get the results as well before the baby gets discharged, and it might be useful. If not, it's better to go for the 48 hours to 72 hours testing, because if you are doing other metabolic screening as well, you can combine with it. And majority of the units also look at the bilirubin levels as well. So you could combine them together so that your success levels of doing tests for every baby could be there. So every either cord or postnatal day between 3rd day to 5th day, samples must be sent for congenital hypothyroidism. That is most important. So where do you test it? You could test in your lab, or you can send it to a central network as well. Filter paper sample processing requires special equipments and kits for assay. I mean, as the sample size is going to be very small, but you can test within your lab as well in a standard way. So either serum or filter paper thyroid hormone assays should be used for screening for congenital hypothyroidism. The choice depends on the local facilities. Why do we choose TSH or over T4 followed by TSH? Ultimately, either of this alone will be a confirmatory. This is only for the screening purpose. For screening, we need to look at how sensitive the test is and what are the false positives that might come in. So with this, if you look at it, so T4 is very good for primary as well as a secondary congenital hypothyroidism, but TSH is more sensitive for a primary congenital hypothyroidism, which is the commonest form as we discussed earlier. The false positives for the TSH can occur when there is neonatal surge of TSH, as we discussed about first 3 days, or transient forms of congenital hypothyroidism. You can mitigate that through by the way of testing the cord blood, or after the second day testing, or repeating the testing again after a week to 10 days. And also it is cheaper, but obviously there's the chance that we might miss the central congenital hypothyroidism when you test the TSH. So worldwide, majority of the places, TSH screening is more frequently done. Hence, the recommendation is to do the primary TSH assay as a part of newborn screening. And also, ISPAE recommends the use of uniform serum unit so that there is no confusion when people use the algorithm to take actions based on the TSH. So the screening algorithm we'll just go through, which was published in 2017. So this is based primarily on the TSH samples. As I said, because of the animation, there are some areas that you may not be able to see. Apologize for that. So the sample, once you do it, if the test comes back as less than 20, or if you have done earlier than 2 days and the TSH value is less than 35, then that is considered as normal and no further action will be required. If the value is more than 20, then you have three kind of options here. If the value is between 20 to 40 or between 34 to 40 in the sample, which is done within 2 days because of the TSH surge, you need to recall them between 7 to 10 days of life for the second screen. At this point, either you could repeat the TSH alone, or if you're doing the venous sample, you could do the TSH and the thyroid profile as well after 3 days of age. So if you have done only TSH and the value is more than 20 in less than 2 weeks of age, or the value is more than 10 at more than 2 weeks of age, again you need a confirmation. Confirmation is only when you do combined TSH and a thyroid profile after 72 hours of age. If the value is more than 40, directly you get the confirmatory venous sample for TSH and a thyroid profile after 72 hours of age. If the value is more than 80, without waiting for the results of the venous sample that you will be sending for TSH and thyroid profile, please start thyroxine as soon as possible, as it has got the implications in terms of the any delay will lead to poorer outcome in the IQ. So once you do the confirmatory venous sample, what are the results options that can come in? One is normal thyroid hormones and normal TSH, which is less than 20 before 2 weeks of age or less than 20 after 2 weeks of age, and thyroid hormone levels normal as per the age corrected values, then it's a normal baby and nothing else need to be done. If you get low thyroid hormones, when they are very low, that is free thyroid less than free T4 less than 1.1, or low T4 which is less than 8 micrograms, irrespective of TSH results, you will be considering treatment for this baby. Or if it is mildly reduced, which is free thyroid less than 1.17 or T4 less than 10 and TSH is more than 20, then also you are starting the treatment. So if the thyroid is low, irrespective of the TSH value, you would be starting the treatment. Simultaneously arrange for imaging as well. If the value of thyroid is normal and the TSH is high, in these circumstances, we repeat the TSH after 2 weeks, and at that time, if the TSH is less than 10, then it's considered as normal, no action is required. If the TSH is more than 10, the persistence of TSH above 10 after 3 weeks warrants treatment until 3 years of age, and then we reassess at 3 years of age. And mind you, you do need to involve the pediatric endocrinologist as soon as possible for these cases. So summarizing the recommendations for the treatment cutoffs. So TSH, if more than 20, a screening sample, you move to the next confirmatory test. So screening TSH more than 40, you directly go to the confirmatory test. And those with the elevated 20 to 40 TSH value, you screen them at 7 to 10 days of age. And before 2 days, if you have done the TSH, it should be, if it's more than 35, you are again taking another screening sample. So when you start the treatment, when it is very low thyroid hormone levels, irrespective of the TSH, or mildly low with slightly elevated TSH, that is more than 20 before 2 weeks, or more than 10 if the baby is more than 2 weeks of age. When it's a borderline, do consult an endocrinologist. And also, as we discussed, you do need to start the thyroxine when the values are persistently above 10 and review at 3 years of age. What are the special circumstances? The preterms, LBW, VLBW twins, routine screening of congenital hypothyroidism needs to be done at the within 2 days, just after the 2 days. And then sick neonates should be screened at least by 7 days and then repeated by around 1 month of age. So at least 2 samples must be done for the special circumstances babies. What is the imaging that you would do? So once congenital hypothyroidism is biochemically confirmed, you can do the scintigraphy can be done up to 7 days after start of the levothyroxine, beyond which it will not be useful. But ultrasound can be done at any age. The type of the test probably you would do will depend on the availability in your local area. Both are complementary. It's actually, these tests are designed to look at what is the cause of hypothyroidism. So if you look at this, so you do the ultrasound, and while arranging thyroid scan, if absent glands are there, non-visualization, obviously it is athyrosis. Ectopic visualization is ectopic thyroid. Similarly, small glands, which is absent or reduced uptake, which is seen in thyroid hypoplasia. So the general guide for treatment is, goal is to normalize free thyroid hormone within 2 weeks, and also TSH within 1 month of age. Radiographs of the knees could help in prognostication as well in terms of how severely the baby is hypothyroid. And the goal is to keep the TSH in the normal range. You can mix with express breast milk in the beginning, and then maybe water once the infant is slightly older. Avoid co-administration with iron, calcium, and soya. Levothyroxine alone is recommended. Start as soon as possible, ideally before 2 weeks of age. Initiate between 10 to 15 micrograms per kilo per day, mixed with breast milk once a day. Preferably at the same time of the day, the drug should be administered. In severe diseases, you can start with slightly higher dose as response could be dosed. Follow-up samples must be taken before the medicine is taken or 4 hours after the medicine is given. Serum T4 and free thyroid T4 levels at 2 weeks, and TSH at 1 month along with a thyroid profile must be done. Following that, every 2 months, the same profile should be done up to 6 months of age, and 3 monthly between 6 months to 3 years, 3 months to 6 monthly thereafter until growth and puberty is completed. So when you suspect a possibility of transient congenital hypothyroidism, they should be evaluated at around 3 years of age for permanence of congenital hypothyroidism and also the need for lifelong therapy. Do not forget hearing test and clinical evaluation for any other congenital malformation. Most of us do know the theory for a long time, and more than 55 years since the implementation of the screening has been happening around the world. But the challenges remain, how do we implement in our own places? So we need to decide what kind of a testing I'm going to do, what sample I'm going to do, and where do I send? And then how do we kind of ensure that the testing results are known? So many times this becomes a challenge that I send a result and maybe the parents get the result. We don't get to see until the parents come to during the follow-up. Some centers, they do inform any abnormal result, but do we have a clear chain of kind of who will be informed and what action will be taken? These kind of minute details have to be worked upon. And the results, once we know, how do we contact the parents, how do we repeat it, and again retesting results also, we have to ensure that we get it and immediate actions need to be taken and consultation with the endocrinologist. So every unit should have their own pathway to ensure that all of these steps are taken. We should measure the number of the babies delivered in our units and number of the tests done. This is a challenge. It looks okay, we're doing 100%, but you need to go deeper to look at every baby, whether they got it tested or not. And once the testing is done, are we getting the results on the right time? That also you can measure that. And also what action is being taken. I can say in the last year, about 1,500 deliveries when we looked at it, all of them did get the TSH at least done. Out of them, 4 babies had higher TSH, which is more than 20, but all of them were less than 40. So the repeat sample was done and endocrinologist consultation was done, and all of them turned out to be primary congenital hypothyroidism. They're all on thyroxine and currently are doing well. But the chances of missing even one baby could be very detrimental for that particular infant. And you could imagine in public sector, these challenges are much more. So see, congenital hypothyroidism screening is a mandatory test that every newborn must have. It's a time-bound testing, and the results and actions are also based on the TSH value. Hence, the SOPs must be in place, and we should be auditing that. And levothyroxine must be started before 2 weeks of age, as early as possible, and further testing to identify the cause as per the endocrinologist advice. And also remember, not all cases of hypothyroidism is detected by TSH screening. Quickly, neonatal thyrotoxicosis. So the most common cause is because of transplacental passage of thyroid stimulating immunoglobulin from mother to Graves, mothers with Graves disease. There could be SGA, preterm, frontal bossing, proptosis, goiter, tachycardia, heart failure, pulmonary hypertension could be there. These disorders are very rare. Thyrotoxicosis in Graves resolves with the clearance of infant circulation. This may take 3 months, but sometimes even up to 36 months. So a mother with Graves' disease, if in the third trimester antibodies are negative and not on any antithyroid drugs, low risk neonate, no follow-up will be required. While in the third trimester, the antibodies are positive or antithyroid drugs are used, then as soon as possible, cord blood or postnatal antibodies and TSH along with the examination of the baby must be done. If they're all normal, low risk, no follow-up required. If antibodies are elevated or unknown, or TSH if they are abnormal, now by day 3 to day 5, history and examination and repeat of the TSH and free T4 must be checked. If they are abnormal, we'll kind of discuss that. If they are normal, but the antibodies are less than 3 times the upper limit, then again, it's a low risk, no further action will be required. If the thyroid antibodies are more than 3 times of the normal, again by day 10 to day 14, that is by the end of the second week, history and clinical examination and repeat of the TSH and free T4 must be done. If they are normal at the time, again, it's a low risk neonate. Remember, thyrotoxicosis is a medical emergency. We cannot afford to miss that. If there are any abnormal thyroid function tests during this time, there are again asymptomatic thyrotoxicosis and symptomatic thyrotoxicosis. Asymptomatic thyrotoxicosis, you consider immediate treatment with antithyroid drugs. And if they're symptomatic, along with the antithyroid drugs, ensure the general care, which is maintaining normal body temperature, fluids, calorie intake, starting treatment with propranolol and iodine if thyrotoxic symptoms are present. And following that, regular review of the TSH and free T4 must be done. As we know that it will resolve over a time. If there is a primary hypothyroidism, still you do follow these infants as they could end up having thyrotoxicosis later on. So every 2 to 3 weeks, you do need to screen biochemically these infants and also do clinical examinations. So treatment is either with carbimazole, which is 750 milligram per kilo per day OD, or propylthiouracil until euthyroid status, and then gradually weaning must be done. Thank you.
Yeah, thank you, Dr. Praveen. So we will take up all the questions later after the second talk. So now I request Dr. Girish. Dr. Girish?
Hello, yeah.
Yeah, you can start your presentation. You can start your presentation.
Okay. Hello. Yeah.
Hello. Yeah, you can start your presentation. Hello. Okay. I think your voice is breaking. Your voice is breaking. Can you speak now?
Hello.
Hello. Your voice is breaking. Your voice is breaking.
Hello.
Hello. Yeah, still a lot of disturbances there.
Is it clear?
No, a lot of disturbances there. Can't hear properly. You can do one thing. You can switch back to the old laptop, and you can speak in that, because a lot of disturbance is coming. Meanwhile, we'll just start taking questions for Dr. Praveen. Can you speak now? Because a lot of crack is there, disturbance is there.
Is it clear now? Hello.
Hello?
Is it clear now?
No. Break is there, a lot of break is there in the voice. You can switch back to the previous laptop, but speak little louder in that. That's it. Or will you remove the headphone and then speak?
Okay. Is it clear now?
No, no. Mic is there. No, you're not audible.
Okay. Just connect on the other system then.
Yeah. You keep there. Start from other system. Kishore sir, you can start taking up the Dr. Praveen. Dr. Praveen.
Praveen, are you there? Praveen,
Hi. Yes, I can.
Praveen, thank you very much for the wonderful presentation. And I think you highlighted all the problems which are associated with the screening and technicalities and SOPs. Very, very good, lucid presentation. And I think we should have a lot of questions, and hopefully we should have some time to answer. Now, somebody has asked a question, no, Prashant, till what age to treat congenital hypothyroidism if TSH is more than 10? After day 3, what is next?
Yeah. So, so yeah, that's right. So the as we discussed, if it's persistently above 10, these babies do need to be treated, and also we do test the full screen of what is the thyroid hormone status as well. But irrespective, we must treat these babies.
Yeah. I mean, till we get some other questions, I just wanted to highlight the largest screening now we have done is from Cloud9. We have screened, we had formed a consortium when we started with Rainbow and Fernandez. Totally now we have screened 120,000 babies for congenital hypothyroidism. We are planning to publish that data. And clearly what we have found is any baby who has a TSH of more than 100 can be guaranteed that it will be congenital hypothyroidism. Any baby who has got between 40 and 80 will have a transient uptake problem. Transient uptake problem usually needs thyroxine only for 1 or 2 years. The clinching diagnosis is you have to do a radionuclide scan to see whether it is uptake problem or absent thyroid. If you confirm it's absent thyroid, then obviously lifelong thyroxine should be given. But if there is thyroid and uptake problem, then usually resolves by 3 years of age. Now, you showed a lot of incidences, differences, Praveen, very good literature search. The differences is if you look at the older papers, most of them have used ultrasound to detect the thyroid. And ultrasound was not very sensitive, especially the paper from Vellore about 10 years ago. Ultrasound was not that sensitive those days. So they would have missed a lot of diagnosis. Nowadays, we have radionuclide medicine. We can't miss any absent thyroid at all. There is one more question, sir. Anti-thyroid drug dosage for thyrotoxicosis in neonatal. Do you want to take that, Praveen?
Anti-thyroid drug dosage. I think I showed that of the thyrotoxicosis. I'll just project that again. So I hope you're able to see that. So carbamazole 750 milligram per kilo per day, once a day, or propyl thiouracil 2.5 to 5 milligram per kilo BD.
Can I ask a question to the all audience? Those who are not screening for congenital hypothyroidism, can you send a message in the chat that you are not doing so that we know who are all not doing screening? I think if Girish is ready, we can start his lecture because there are no more questions right now.
Hello. Am I audible now?
Dr.
No,
Girish,
very faint.
you need to come closer and speak very loudly, very loud. Whatever maximum strength you have got, with that you speak, Dr. Girish.
I just started the slide sharing. Is it clear?
Yeah, yeah.
Still not audible, Girish. Maybe you need to use a mobile phone or something like that to log in, because that may be better with the speaker.
I'll just check it on microphone system once. Yeah.
So the reason I asked, if anybody is not doing hypothyroidism screening, that's going to be a medical legal issue, because the NNF and IAP have recommended that all babies should be screened for hypothyroidism. If anybody is not doing the screening, you better start now.
Hello.
Yeah, Dr. Girish.
Am I audible now?
Girish, go ahead.
Go ahead. Start. But try to speak as loud as possible.
Okay. Good evening, everybody. Sorry for this disturbance. Is the screen visible? Hello? Hello? Am I audible now?
You're audible and we can see the screen.
Okay, fine. Thank you. Good evening, everyone. And thanks NNF for giving me this opportunity to be here with you people and share my thoughts on the congenital adrenal problems in the neonates. The congenital adrenal problems in neonates is one of the probably the second most common endocrine problems that we encounter in the neonatal practice. After the thyroid problems, this is probably the second most common endocrine problems. To understand the endocrine problems and the adrenal problems, we must know the basic adrenal development and adrenal physiology. So I will just start with the adrenal basics, and then afterwards I will continue with the problems. To start with, we all know that the adrenals has two parts. One is the adrenal cortex and adrenal medulla. Both are sitting very closely with each other, but developmentally both are totally different. Adrenal cortex develops from the mesoderm, while adrenal medulla develops from the neuroectoderm. This adrenal cortex has three parts: the zona glomerulosa, fasciculata, and reticularis. These three parts are seen in the adult adrenal cortex. However, if you look at the fetal adrenal cortex, it has only two parts, only the zona glomerulosa and zona fasciculata. Reticularis actually develops in the later part of the life. Three important things we should remember here is the developmental phase, how it happens. The adrenal gland development starts as early as 4 to 5 weeks of the intrauterine life. And simultaneously, the hypothalamic pituitary adrenal axis is also formed, and the control is established by 6 to 8 weeks of the life. Simultaneously, the genital differentiation is happening, and genital differentiation is complete by 8 to 10 weeks of life. Here I'm talking about the genital differentiation basically because this chronological developmental order is very important to understand the pathophysiology of the diseases caused because of these adrenal problems. Coming to this screen about what's the function of adrenal hormones production. Basically, this if we just look, the cholesterol is the most basic substrate for all the hormone production in the adrenals. The zona glomerulosa synthesizes from cholesterol the aldosterone. There are various enzymes are involved in the production of this aldosterone. There is no need as of now to go into the depth. I will be talking about the enzyme system later on. The zona fasciculata synthesizes the cortisol from this same cholesterol, while zona reticularis synthesizes the androstenedione from this cholesterol. What is more important is this androstenedione can get converted into either testosterone or estradiol in the periphery. The conversion to estradiol happens in the placenta, and conversion to testosterone happens in the fetal testicular tissues. Now, entering into the congenital adrenal disorders. If we just look at the list of the congenital adrenal disorders, there are plenty of disorders that can happen. However, most of the times what we clinically encounter are very few disorders of this. So I will be discussing in detail about the congenital adrenal hyperplasia. This is the most common congenital adrenal defects that we encounter in clinical practice. However, I will be talking a little bit about the familial glucocorticoid deficiency, neonatal adrenal leukodystrophy, and adrenal hypoplasia congenita. Even though my topic is about the congenital disorders of the adrenal, I have just added two more topics, the adrenal hemorrhage and iatrogenic adrenal insufficiency, basically because this is a very important and common condition. So I just thought of covering this part also. Let's start with congenital adrenal hyperplasia. The congenital adrenal hyperplasia is actually not a single disorder. It's a family of disorders where the primary pathology is the defective cortisol synthesis. The zona fasciculata fails to synthesize the cortisol. Because cortisol synthesis is not happening, there will be feedback increase in the ACTH, and this increase in the ACTH causes the hyperplasia of the adrenal gland, leading to congenital adrenal hyperplasia. This is sometimes associated with aldosterone deficiency. It is not mandatory. And sometimes it is associated with androgen excess. Again, this is also not mandatory. As I told you, it's a family of disorders. So we have various types of congenital adrenal hyperplasia. This table is very, very essential, important. Let's spend some time on this table. There are 5 types of congenital adrenal hyperplasia. The most common is the 21-hydroxylase deficiency. As we can see, nearly 90% of the congenital adrenal hyperplasia is because of the 21-hydroxylase deficiency, while 11-beta-hydroxylase deficiency will contribute to rest of the 5 to 8% of the disorders. Rest other 3 disorders, that's the star protein deficiency, 3-beta-hydroxysteroid dehydrogenase deficiency, and 17-alpha-hydroxylase deficiency. All these 3 hardly contributes to 1% of the congenital adrenal hyperplasia. Of these 5 varieties again, the androgen excess is seen in 21-hydroxylase and 11-beta-hydroxylase. As I already told you, these 2 contributes nearly to 99% of the cases of CAH. So 99% of the cases of CAH will have increased androgens, and there is a chances of virilization of the female fetus. However, if you just see the other 3, the androgen level actually is reduced. So in rest 1% of the cases, androgen levels is actually low, and that can cause under-virilized male babies. The mineralocorticoid production again is increased only in 2 varieties, 11-beta-hydroxylase and 17-alpha-hydroxylase. So these 2 can present with hypertension, but most important is hypertension is usually not a neonatal presentation. These kids tend to develop the hypertension somewhere after the age of 1 year. But more important is because the mineralocorticoid is elevated, these kids will not go into salt wasting crisis, while all other varieties can go into salt wasting crisis. In this slide, I'm actually just showing all the enzymes that are deficient, but all we have to note is the most common is the 21-hydroxylase deficiency, followed by 11-beta-hydroxylase deficiency. What is important here is when we are doing the neonatal screening, we are measuring the 17-hydroxyprogesterone. Please note that the neonatal screening is targeted not to pick all types of CAH. It is to pick 21-hydroxylase, the most important varieties which contributes to 90 to 95% of the cases. This is the one which is targeted and picked in 17-OHP screening. However, as you can see, even 11-beta-hydroxylase deficiency can cause increased 11-deoxycortisol, which sometimes can be picked as 17-OHP in the screening test. So we may be able to pick some cases of 11-beta-hydroxylase deficiency. At the same time, because of 3-beta-hydroxysteroid, some cases may be picked, but in star protein and 17-alpha-hydroxylase deficiencies are never picked in our routine congenital adrenal hyperplasia screening. This is something which we must remember. Coming to the gene defects associated with the CAH, the genetics has improved a lot in the recent past. So all the genes which are responsible for this disorder have been mapped. All the 5 genes are known. All are autosomal, then transmission is autosomal recessive. The next is, why should we worry about this congenital adrenal hyperplasia? The most important reason why we should worry about this disease is the effect of the disease starts even in the fetal life, and most important is the virilization of the female fetus. So as I told you, the fetal manifestation is limited to the female fetus with the form of virilization in cases of 21-hydroxylase. The rare 1% of the cases, even the male fetus gets under-virilized. They may present with the ambiguous genitalia. However, the most common 21-hydroxylase deficiency in that cases, the male fetus will escape the genital problems, but they present somewhere at the end of second week or early part of the third week of life with a salt wasting crisis. This is more important because most of the times they will have normal genitalia. They will present with failure to thrive, hypoglycemia, hyponatremia, with severe hyperkalemia, with shock, and if not recognized and treated early, it will lead to the death. So this neonatal manifestation in male is something which is very devastating. However, not all CAH presents either fetal or neonatal, but some may present in the later part of the life with the precocious adrenal arc or with the hirsutism, acne, and fertility issues. As I told you, it is a spectrum of the disease. The CAH 95%, nearly 95% are 21-hydroxylase deficiencies, while rest 5% comes with the other enzyme deficiencies. Of this 21-hydroxylase deficiency, again, the most common presentation is actually non-classic. The non-classic incidence is about 1 in 1,000. However, it is not important basically because it is not fatal disease. Usually, it is not present in the neonatal period. Most of these cases presents either in the pediatric adolescence or sometimes even in the adult life. What we are worried is with the classic presentation. In the classic presentation, nearly 75% will present as salt wasting and 25% will present as simple virilizing. Basically, the 75% salt wasters will also have virilization, while in simple virilizing where it is, salt wasting is not seen. What the screening we do is targeting this classic cases of 21-hydroxylase deficiency, and this is the one which is actually dreaded, which can cause the fatality as well as the virilization. Coming to the diagnosis and the treatment part, the diagnosis can be done either in the fetal way, the life itself, or in the neonatal time. Coming to the fetal diagnosis, the fetal diagnosis can be established by either chorionic villus sampling or by the amniocentesis. Normally, the chorionic villus sampling is done somewhere between the 9 to 11 weeks of gestation, while amniocentesis is done somewhere around 12 to 14 weeks of the gestation. The fluid collected is sent for gene analysis for the particular mutations. In the case of 21-hydroxylase, it is seen in the case of the cytochrome P450 gene. So that mutations are analyzed. I have also written here plus or minus fish for XY chromosomes. Basically, diagnosing the fetal sex helps for the fetal management. So in Western countries, they do the fish to diagnose whether it is the male or the female, because it's the female fetus that can get affected. Unfortunately, because of the PCP-NDT Act in India, we cannot do this fish. So we have to just do only the gene analysis. Presently in India, most of the places the gene analysis is available, is accessible. However, if there are places where the gene analysis is not possible or there is a significant delay is there for the sample they get processed, we can consider going for the chemical estimation of 17-hydroxyprogesterone also. However, it is nowadays outdated. Coming to the genotype decides the disease spectrum. As I already told, the disease can present as a non-classic variant or the classic variant. And even in the classic variant, it can present either as a severe salt waster or simple virilization form. And what we are testing in the either amniotic fluid or in the chorionic villus biopsy is the genes. In this condition, fortunately, the mutations has a very good genotype to phenotype correlation. The correlation of nearly 80 to 90% exists. So in the rest, about 10 to 20% of the cases, genotype may not truly define the actual phenotype. Coming to the approach to a pregnant mother who is at the risk of having CAH in the fetus. Most of the CAH actually happens following the de novo mutation. So it may not be possible for us to prevent each and every case of the fetal CAH. So we will be diagnosing the CAH once the baby is born. However, if the mother have previous pregnancy with had a baby with a CAH, or in a rare instance where the couple themselves have the CAH, we can consider the diagnosis in the fetal life itself. Once such situation exists, the dexamethasone is started to the mother as early as 6 weeks of the pregnancy, but it must be started before the 9 weeks of the pregnancy. The rationale for starting the dexamethasone is the dexamethasone can cross the placenta while hydrocortisone cannot, it gets metabolized. So once the dexamethasone crosses the placenta, it inhibits the fetal adrenals, hypo and ACTH production is inhibited. So fetal CAH is prevented, causing the virilization of the female fetus is avoided. To prevent this, we must be starting the dexamethasone before the 9 weeks of the gestation. So once the pregnancy progresses to 9 to 14 weeks, either CVS or amniocentesis can be done. And once we make the diagnosis, either the male fetus or unaffected female, we can stop. In India, obviously, we cannot differentiate whether it is the male or the female. We can only differentiate whether it is an affected fetus or unaffected fetus. If it's an unaffected fetus, we can stop the medication. But if it's an affected fetus, we have to continue the dexamethasone throughout the pregnancy. However, the dexamethasone is not something which is a very minor medication. It is associated with serious problems. First and foremost thing is, if we take around 8 fetus, in the cases of 8 fetal suspected CH cases, roughly 4 fetus will be males and they do not require any treatment. 50% of them do not require treatment. Other 4 female, because it's an autosomal recessive disorder, only 25% of them, means one of the 4 females, will have the problem of virilization. So to prevent one female baby getting virilized, we have to expose 8 babies for the dexamethasone therapy. 8 fetus has to be exposed. Those who get, even for a transient duration, the dexamethasone exposure, they tend to develop both short-term and long-term problems. Short-term, they can have IUGR, and in the long-term, the behavioral problems and cognitive deficits have been noted. Also, the mother tends to develop various adverse effects due to dexamethasone. She can develop the hypertension, she can develop the edema, so she can have repeated vomiting. So many complications can develop in the mother. So because of these various problems with the dexamethasone therapy, the dexamethasone is not considered a standard of care. Most of the times, dexamethasone has to be given only in the research setting. However, there are now the research is happening where a maternal cell-free fetal DNA can be analyzed. The maternal blood sample is taken as early as 4 weeks. Once the pregnancy is confirmed, maternal blood sample is taken and cell-free fetal DNA, which is there in the maternal blood, is analyzed using targeted massive parallel sequencing. It's a genetic technique. I'm not sure what exactly they do. Basically, they will take the maternal blood sample, they will take father's blood sample, and they are going to analyze and finally make the diagnosis whether the fetus is affected or not as early as by 8 weeks of the gestation. So we can avoid giving dexamethasone to the mother, and we can exactly make the diagnosis of which fetus is affected, and we can exactly treat only that individual fetus which is getting virilized. As of now, it is experimental and is not possible to use this technique as of now. Coming to the neonatal diagnosis of CAH. Congenital adrenal hyperplasia is one disease which qualifies for the routine newborn screening. It's a common disorder. It can be easily screened with 17-OHP. It is possible to treat the disease with a medication. So this actually qualifies for routine newborn screening. Unfortunately, in India, in the most of the places, routine newborn screening of CAH is not being practiced. Recently, in the January of this year only, the Indian Pediatrics has published a paper where they have given the guidelines for the neonatal screening for CAH. As per their guidelines, any term gestation, a dried blood sample has to be collected between 2nd to 7th day of life. However, in 3 scenarios where the baby is born premature, less than 37 weeks, or baby is sick in the NICU, or the mother has used steroids for whatever may be the reason, including antenatal steroid prophylaxis to the mother, then a repeat sampling is mandatory after 2 weeks of the age. The basic reason is in all these 3 scenarios, the 17-OHP level is falsely elevated. So when we do the early sampling, the chances of false positive is very high. So once we take the sample on the filter paper, it is going to be analyzed by fluoroimmunoassay for 17-OHP. Fluoroimmunoassay for 17-OHP is a very good test with a high sensitivity, but unfortunately, the specificity is quite poor. So once you have the elevated levels, then again you have to take another sample from a different circle, and again the fluoroimmunoassay is going to be done. And if it is more than the cutoff, then that is an indication that the test is positive, the screening test is positive. At this level, the baby has to be called back. We have to do a repeat venous sample for confirmatory tests. One problem with this is the chances of as I told you, sensitivity is pretty high, but positive predictive value of this fluoroimmunoassay is very poor. In fact, it is just 1%. So if we recall 100 babies, about only one baby will have CAH and 99 will not have CAH. To improve this, in some labs, what they do is they will take from the previous whatever filter paper was sent, from that only they consider doing LCMS as a second tier test, and rarely they can even consider doing genotyping as a second tier test. What is important here is if we are already sending the sample to some of the labs for the newborn screening, we have to ask them and confirm whether they are sending with the routine first line only or they are doing the second tier test before reporting to us. We should be knowing that one. Following the second tier test, the chances of false positivity is very, very low. So once the baby is, we have the report, the confirmatory sample of 17-OHP is done and the child is started on the treatment. All these confirmatory tests can be completed before 2 weeks of the age. So the babies will not end up in salt wasting crisis. However, if there is an unfortunate baby who has not underwent any newborn screening and presents with some symptoms, or the baby is born and is a virilized female, then we can directly go ahead with a confirmatory test without going for newborn screening. These are the cutoffs that have been published. These are the various cutoffs taken from Indian population. Ideally, we should be following the gestational age, which is more sensitive and specific. However, if we do not know the exact gestational age, we can actually take even the birth weight cutoffs. These are the cutoffs actually published from the study from Delhi. Coming to the treatment of congenital adrenal hyperplasia. The most important is if we are not following the newborn screening, these babies can present with salt wasting crisis. Most of the times, these are the male babies who present somewhere between 10 to 15 days of life. They present with failure to thrive, excess weight loss. The baby will be sick with hyponatremia, hyperkalemia, even shock and hypoglycemia. If not properly diagnosed early, the hyperkalemia can lead to cardiac arrhythmias and cardiac arrest. So the diagnosis has to be, the suspicion should be high. We should start treatment immediately with hydrocortisone once we take the sample for the confirmatory test. All the babies, once diagnosed and initially stabilized, has to be put on long-term oral hydrocortisone therapy. Hydrocortisone is the preferred drug, usually used around 10 to 15 milligrams per meter square body surface area to be used. And it is preferred basically because its effect on the the baby's bone growth is very less. So bone growth is relatively preserved, one. And secondly, hydrocortisone is very good in suppressing the ACTH. So that's why the oral hydrocortisone is the preferred drug. It has to be given orally 3 times a day in divided doses. Some of these cases may require even fludrocortisone. Generally, the fludrocortisone is used initially at 0.1 to 0.2 milligrams, but most of the times after stabilization, they will require relatively less dose of 0.05 to 0.1 milligrams per day. We should remember that all these babies will require testosteroids. We have to either double or even triple the dose of the steroids, hydrocortisone, whenever they develop some sickness. The most important part will be the parent education. We have to explain them it's a lifelong treatment. The very good follow-up is essential. They should understand and they should themselves be ready to implement the testosteroids if there is any sickness happens. And lastly is the surgery for ambiguous genitalia. For the unfortunate cases where there is an ambiguous genitalia is already there, it has to require surgical treatment. In this, the salt wasting crisis can be prevented if we implement newborn screening. The surgery for ambiguous genitalia can be prevented if we do the fetal therapy. However, as we already know, the fetal therapy is possible only for the second baby. So first baby can get affected and will require this surgery for ambiguous stimulation. Whatever I discussed till now is regarding the most common variant of CAH. 95% of them are 21 hydroxylase deficiency. So that is what I have actually discussed. However, the other tests, other forms of CAH may or may not be picked by the screening test. This is something we should remember, because if there is, we have to evaluate a baby for a DSD, the screening test will not rule out all forms of CAH. They may or may not manifest in neonatal period. Salt wasting is variable, and the management line, however, remains the same across all the types of CAH. Coming to the next entity, the familial glucocorticoid deficiency. The familial glucocorticoid deficiency basically is the unresponsiveness of the ACTH. The adrenal gland is not responsive to ACTH. The ACTH receptors are mutated. So there will be no ACTH levels are grossly elevated. However, the cortisol level is very low. Most of the times, their neonatal presentation is mild. They present with some hypoglycemia, not very severe. They may or may not have hyperpigmentation. We can look at the oral mucosa. If there's a hyperpigmentation, it can lead to thinking in this direction. Otherwise, most of the times, these hypoglycemias will respond very well to oral feeding, and most of the times we will miss this diagnosis. So most of them will be diagnosed actually in the later part of the life, even though the neonatal manifestations are known. Mineralocorticoid function is normal. They require only the supplementation with hydrocortisone. Coming to the neonatal adrenal leukodystrophy, it's a part of the peroxisomal disorder like Zellweger syndrome. Even though it involves, as the name itself is telling, it involves both adrenals as well as the cerebral white matter. The neonatal presentation is with dysmorphic facies. Actually, I wanted to put this one photograph here, but being an online platform, I was not sure there might be some copyright infringement. If you just put in the Google, you can clearly make out, you can see that photographs are there. The facies is clearly abnormal. At least, if not, we can put the diagnosis, we can definitely recognize that it is some syndromic facies. The neonatal presentation is in the form of neonatal seizures, not in the adrenals. The adrenal the insufficiency develops in the later part of the life. Coming to the next entity, adrenal hypoplasia congenita. Adrenal hypoplasia congenita, though the name says it is hypoplasia congenita, the presentation is not neonatal. This disease is responsible for only 2% of adrenal insufficiency in children. It affects only the adult adrenal cortex. The fetal adrenal cortex is spared. So presentation starts only by the age of 1 to 2 years. This disease is X-linked inheritance. The DAX gene mutation is seen. This DAX gene is very closely located to XP21 gene. So because of this close association, sometimes this there will be a contiguous gene involvement, causing there may be association along with this with either AAA syndrome or with the Duchenne's muscular dystrophy may be there. In this case, there is no androgen excess and treatment requires only hydrocortisone with fludrocortisone. The treatment again is lifelong. With this, I'm completing the congenital adrenal problems. However, I'll just talk briefly about the adrenal hemorrhage and the iatrogenic adrenal insufficiency. The adrenal hemorrhage is surprisingly probably the most common disease, adrenal disease that we encounter. If we happen to do a routine ultrasound of the babies, nearly 3% is the incidence of adrenal hemorrhage. However, only about 1 in 1,000 cases present with the symptoms. So majority of them remain asymptomatic. The etiology is either birth trauma, especially following breech delivery, or sepsis, neonatal sickness causing coagulopathies, or asphyxias. Most will remain asymptomatic. They are either picked with an incidental finding in cases of the ultrasound done either in the neonatal life or in the later part as adrenal calcifications. If they present with symptoms, it is either as mass per abdomen, or if there's a bilateral bleed is there, they can present with adrenal insufficiency. So whenever a sick baby is having hyponatremia with hyperkalemia, it is better we draw a sample for the cortisol level and start with the hydrocortisone to rule out this adrenal insufficiency. If it is unilateral, they can present with a mass per abdomen. Sometimes the bleeding may be so massive that they can present even with a shock. If the mass is there, then follow-up scan after 1 week or so will show the resolution. and it is a lot easier, and usually it won't affect the life unless the patient goes into the shock. The treatment is just symptomatic in this condition. Coming to the last entity, the iatrogenic adrenal insufficiency. Nowadays, we often treat most of the premature babies are treated with ventilation. They survive well. However, the incidence of BPD is not going downward. Even though the use of steroid is relatively less compared to the past, some of these babies may get exposed to for steroids when used for BPD. Even though we use a low dose steroids, whenever we use it for a bit good duration, say 1 week or 2 weeks, many a times it leads to a slow grade suppression of the fetal neonatal adrenal cortex. Even though we withdraw the steroids later on, the response to the stress remains poor in these babies, and this can persist to the tune of almost up to the age of 6 months to 1 year of the age. So whenever these preterm babies get discharged, even though their steroids we have already stopped, if they happen to come back, say at the age of 3 months or 6 months with any other sickness, say respiratory infection or something, they may have some degree of the adrenal insufficiency. And these are the babies who might require the stress dose steroids. Even though this is something which is iatrogenic and usually ignored, we should be remembering this and treat these babies with the stress dose steroids. And before we start the stress dose steroids, it is good to take a sample for the cortisol to prove that there was an insufficiency to stress. With this, I complete my presentation. Thank you. Hello?
Yeah. Hello. Yeah. Thank you, Dr. Girish.
Can you stop sharing?
Yeah. Stop sharing. Yeah. Kishore sir?
Yeah, I'm here.
Yeah. So I request all the participants to post the question. We will forward it. Over to you, Kishore sir.
Dr. Girish, thank you very much for a brilliant lecture. Congenital hypothyroidism always remains an enigma for most medical students and postgraduates. You simplified it very, very easily. And I think the two brilliant lectures by Praveen and Girish now are open to any questions from the audience.
Audience can raise their hands and we will allow them to ask question. Kotreshi sir, do you?
Hello sir. Yeah. I very much appreciate for both speakers given a very good importance of what is the steroidal hormonal balance is occurring in the antenatal period also. I got one question to Dr. Girish. Is it the oral hydrocortisone available?
Yes, sir. Tablet Hyzone is available. 5 milligrams is the strength. Tablet Hyzone, it is there.
Pardon?
Sir, it is tablet
there.
Hyzone.
But
it's available. 5 milligram strength is available.
Tablet Hypo.
Hyzone, sir.
Okay. Another question is, these things can be prevented by antenatally?
So the one thing is a de novo mutations. When the first fetus gets affected, we cannot prevent it. We won't be knowing. We'll be just picking it in the neonatal period. But once the first kid is affected, we can diagnose it for the second baby. So the fetal diagnosis is possible for the second baby.
Okay. Thank you, sir.
Yeah, thank you.
Girish, if it's a preterm baby,
yes, sir.
Would you advise to do screening soon after birth or at what age?
All the babies, we have to send one screening at 3 days of life. However, even though if it is abnormal, it has to be repeated again after 2 weeks of age. After 2 weeks of age. Because normally all preterms will have elevated 17 OHP levels.
So there is one question from Facebook to Dr. Praveen. They've given a scenario. Term baby, at the time of discharge, at 48 hours of life, the TSH is 12 and the baby's weight is 3.2 kg. After 2 weeks of life, the parents are very apprehensive about the report of more than 10 and they repeat. And it comes as 16. And then at 3rd week of life, baby develops fever and convulsion. So after 48 hours of febrile convulsion, the repeat value is 18. So how we should approach this case? Do we have to consider this as a rising TSH level and start treatment, or how we should proceed practically?
Yeah, interesting actually. So basically we're saying that the first screening, it is negative. Then we have done some reason. I don't understand the reason why we did the thyroid for a baby who came with different
parents
symptoms.
wanted to repeat itself. That's why it's on the request of the parents they've repeated. Yeah.
Correct. So what we could look at is like, one is the other symptoms and signs of any hypothyroidism. Second one is we would screen to look at whether the hormones are also reduced or not. And that is important. If the hormones are reduced and the TSH is high, definitely that is hypothyroidism. Now, which cause it is, that could be different. So it may not be your primary thyroid related as such. There are, secondary causes could be there. So definitely TSH of that number is high, and that should be considered abnormal. However, you confirm with the thyroid hormones testing as well.
So do you suggest any radionucleotide scan for this? And at 1 month of age, baby weight is gained by 1.5 kg, and the value still remains at 16.
Sorry, 60, right?
16. It's between 10 to 20. They are trying to tell the value is between 10 to 20. How we should approach if the value remains in that particular between 10 to 20 range?
Okay, sorry, I thought it's 60. That's what I thought. No. If it is less than 2 weeks and the value is less than 20, nothing to worry. If it is more than 2 weeks and even if it's above 10, that is automatically significant. You should go into, again, every investigation, which is you start ultrasound, you do the technician scan, and also you start medications. And of course, you would have done the thyroid hormones as well. So 10 to, up to 20 before 2 weeks is okay. Repeat this screening. If it is persistently above 10, then it falls into the congenital hypothyroidism region only.
So Dr. Hiranna B. Alemani has raised
yes, sir.
Yeah.
Sir, my question to Dr. Girish. Hello.
Hello. Yeah, tell me.
Yeah, you're audible. Please go ahead.
Sir, my question to is Dr. Girish, sir.
Hello. Yeah.
Sir, during infancy, we encounter a lot of babies with constipation.
Okay.
Hello.
Hello. Yeah, tell me.
Hello,
complete
sir.
The question. You're audible. We are able to hear you. Please complete the question.
Sir. We encounter a lot of babies with constipation. Initially, they say they pass low stool. Later on, constipation. And recently, I come across 3 to 4 babies in a very small setup near Gadag, where the pediatric surgeon advised for 1 year baby also do this thyroid profile.
Okay.
What is your this one, sir? In case of constipation, yes, sir.
This question is directed to Dr. Praveen.
Yes.
I spoke on CAH. Okay.
Yes, sorry, sir.
Dr. Praveen.
Okay. Yeah, I joined later. This one.
Dr. Praveen.
Sorry, ಇನ್ನೊಂದ್ಸಲ ಹೇಳಿ ನನಗೆ ಕಾನ್ಸ್ಟಿಪೇಷನ್.
Sir, constipation in infancy, sir. Hello, sir.
ಹೌದು.
Constipation ಇರುತ್ತಲ್ಲ ಸರ್, ನಮ್ಮಲ್ಲಿ constipation ಇರುತ್ತಲ್ಲ ಸರ್, ಆ ಬೇಬೀಸ್ಗೆ ನಾವು ರಿಮೋಟ್ ಪೆರಿಫರಲ್ ಇದ್ರ ಪ್ಲೇಸಸ್ ಅಲ್ಲಿ ಮಾಡಿರಲ್ಲ ನಮ್ಮ ಥೈರಾಯ್ಡ್ ಸ್ಕ್ರೀನಿಂಗ್. Constipation ಬಂದಾಗ after excluding so many reasons, if I refer to a pediatric surgeon, sometimes they say do thyroid profile. What is your this one? Yes, sir. What is your this one?
Oh, definitely. See, that's one of the presentations of hypothyroidism. ಖಂಡಿತ ನಾವು TSH T4 ಮಾಡಲೇಬೇಕಾಗುತ್ತೆ ಈ ಸರ್ಕಮ್ಸ್ಟೆನ್ಸ್ ಅಲ್ಲಿ. But my first is we should look at somehow doing the TSH screening, even if it is a nursing home. Kishore in front of me, he will kind of scream out. Now, Kanita, ಅದು ಮಾಡ್ಲೇಬೇಕಾಗುತ್ತೆ. ಪ್ಲೀಸ್ TSH ಒಂದು ಮಾಡಿದ್ರೆ ಈ ತರ
Yes, sir.
ಪ್ರೆಸೆಂಟೇಷನ್ ಪ್ರಿಂಟ್ ಮಾಡ್ಬೋದಲ್ವಾ ಅಂತ. ಸಿಂಪಲ್
ಆಮೇಲೆ ನಾವು ಹಾ ಸರ್, ಆಮೇಲೆ ಮಾಡಿದಾಗೆಲ್ಲ ಮೋಸ್ಟ್ ಆಫ್ ದ ಟೈಮ್ ಇಟ್ ಕಮ್ಸ್ ನಾರ್ಮಲ್ ಸರ್, ನಾರ್ಮಲ್ ಬಂದಿರ್ತವೆ. ಹಲೋ
ವೆರಿ
ಹಲೋ
ಗುಡ್.
You are audible. You are audible. You are audible. You are
sir,
audible.
that's all sir, that's all my question, just to clarify. Okay sir, thank you sir, thank you.
Yes, sir. Is there any other question, sir? Kishore, sir. Yeah, Kishore, sir.
Praveen, one more question has come. Cutoff value to call it as a low TSH levels.
So I don't remember the number, but I think 1 or less than that, I think. So it's again age dependent. The NAMO tables are there. I can't remember on top of my head, but there is a level where we should be careful about reducing the thyroxine level and trying to see whether it is a transient one and we can withdraw for 4 weeks and then retest it.
One more question, Praveen, for you. At below what gestation age, if the initial TSH were to be normal, considering the possibility of panhypopituitarism in mind, when do you suggest repeating the test?
Every preterm, as I did mention, that we have to repeat it at least twice, whatever the gestational age, but up to a month of age. But there are studies which are, pushing towards more, even up to 3 months as well, repeating the screening. But generally, at least 2 values, we should be doing it.
Yeah, there was a large European study headed by Switzerland who said ideally you should do both T4 and TSH if you want to rule panhypopituitarism. But the cost of the treatment, screening will become higher. Currently, no other country is doing both TSH and T4 except Switzerland. So if you are worried about panhypopituitarism, I think it's worth doing T4 and TSH after 2 weeks. Praveen, one more question for you. Any role for thyroglobulin measurement in cases of congenital hypothyroidism?
Especially, it is there, especially when you have thyroid, TSH is elevated, but T4 seems to be normal, but you still have features of hypothyroidism. But generally, either perchlorate test or you could speak to the endocrinologist. They definitely will advise that in these borderline cases, not as a routine, but these cases definitely there is a role.
There is one question from Facebook.
One more, free T3 and total T3, which is important, and what is the importance of T4 for you, Praveen?
Free T3 and sorry?
Free T3 or total T3 and T4, which is important.
Yeah, so but as again, like we kind of discussed earlier, see the free thyroid is responsible for your all functionalities. So if your free T4 is elevated, then that means that you have adequate kind of a thyroid. But if you still have TSH higher, then that means that there is a block at the tissue level. So free T4 is definitely you'll have to do along with the TSH when you are screening for hypothyroidism. So T3, generally T4 converts into T3. So again, doing that is not of any significance. So better to do T4 and free T4.
So there is one more question. Suppose if the TSH done at 48 hours is 6 and mother is hypothyroid from birth. So there's a family history, and even her grandparents are also, grandparents also have thyroid issues. Is there any evidence to repeat it again, say after 2 weeks or 3 weeks? Should we routinely do a repeat screening after 2 weeks or 3 weeks, or is there any specific guidelines like that? If there is a family history, but the initial 48 hours TSH, they have done only TSH, which has come normal. So how should we proceed in such scenarios?
Yeah, no, there's no role. Some people used to do a 10 to 14 days repeat to see whether there's an increasing trend of TSH, assuming that by then the action of the mother hypothyroid status or the drug would come down. But no, currently we just do as a routine like any other mother.
Okay.
Prashant, there was a small study done in Australia, but looking at the maternal and grandparental hypothyroidism, there is no implications of maternal and grandparent hypothyroidism to congenital hypothyroidism as such. And usually if there's a family history, there are only two things that matter. One is thyroid antibodies. The other thing is iodine deficiency. So you need to have a diagnosis of what is the familial hypothyroidism due to. Is it due to antibodies or is it due to iodine? That needs to be looked at. So if the diagnosis is not clear, it is worthwhile pursuing the diagnosis in the family circumstances. But hypothyroidism, congenital hypothyroidism is due to absence of thyroid gland and not due to the maternal transfer lacking or anything like that. I don't see any questions here anymore, unless you have any questions from Facebook, Prashant.
There is one question, sir, that is regarding the free T4 levels and TSH level post-treatment. So when baby is hypothyroid, started on thyroxine, and what should be the, suppose if TSH drops down to 0.5, what is an ideal situation where we have to reduce the dose? Based on the level. Suppose if it drops down to 0.5 and less TSH, so how we should proceed with the monitoring and treatment management of the dose? That is what they meant.
Correct. So that's what I was mentioning earlier. If it drops down, so you don't want suppression as such, so you might have to reduce or tweak the dose of the thyroxine and then repeat the test to see whether TSH normalizes. Maybe 2 weeks, 3 weeks down the line, you repeat the thyroxine TSH level after reducing the dose. But yeah, that's how I would do it. But maybe they should speak to the endocrinologist if they're concerned that it is going very low.
Okay. So that's all, sir. Questions. So audience participants, if you have any questions, you can raise your hands. We can ask with our speakers. So
thank you, Praveen and Girish, for your wonderful lectures. And I think you both made the most difficult topics look so simple. And I'm sure everybody has enjoyed and understood. That's why not that many questions today. With that, we can close the session. Thank you very much.
Thank you, all the speakers. Thank you, Kishore sir. Thank you, Dr. Praveen and Dr. Girish. And thanks all the audience. We know that it is a little tedious. We request all the participants to put your full name and place of work so that it's easy for us to identify. Thank you very much. Thank you. We are concluding the meeting. Thank you.
Thank you so much. Thank you.